Thank you, Serena. Before I start my talk, I'd like to acknowledge the traditional custodians of the land in which all of this work was done, the Bejical people of the Eora Nation, and extend my respects to their elders past, present, and emerging. So similar to Johan, I've got the take-home message there in my title, just in case I go over time. I will mainly be focusing on the data that we've accumulated at the 24-month time point because the earlier time points have been published. So the work that we've been doing on long COVID really started from the ADAPT study, which was a prospective cohort study that was looking at post-COVID-19 recovery. This was established in Sydney at St Vincent's Hospital in April 2020. We recruited 147 participants with confirmed SARS-CoV-2 PCRs in our testing clinics, and then we followed these patients longitudinally. We were one of the first in Australia to define long COVID, and this was around August, September 2020, a year before the WHO. Our definition of long COVID was at 4 months post-infection, and this is based on the presence of any of the following symptoms: fatigue, dyspnea, and chest pain. So our patient characteristics, out of the 147, 21% were defined as long COVID. So N equals 31, sorry, the pointer is a bit delayed. We also, from the same cohort, had age and gender matched controls, and they're very similar in age. Majority being women, slightly higher than men, at 48%. And I think one thing that makes our ADAPT cohort unique is we also had another arm of patients we called ADAPT-C, who were patients that developed or had common cold coronaviruses, so the 4 common endemic strains that goes around every year, as a control group to see that everything that we basically discovered in long COVID is specific to SARS-CoV-2. And then we also had 2 uninfected healthy control cohorts from both St Vincent's and University of Melbourne, and these were archival PBMCs stored and serum stored prior to SARS-CoV-2 emergence. We followed these patients longitudinally now up to 2 years, collecting comprehensive clinical and biological data. And I just want to highlight that a majority of our patients got vaccinated, so fully vaccinated at the 18-month time point, and that's 2 doses of either the AstraZeneca or the Pfizer vaccine. And this data is already published in January last year in Nature Immunology. What we found when we did the immunoprofiling was increased type 1 and type 3 interferon, as Hongjian mentioned. We found high interferon beta at 8 months compared to the matched controls. And this is quite surprising because these pro-inflammatory cytokines are normally reduced by this extensive time point. We also found an absence of what we called unactivated naive T and B cells. So there are a small cluster of naive cells that were actually absent in the long COVIDs at 4 months, and they didn't reconstitute at 8 months. And so a lot of our finding has been validated in other cohorts around the world, including type 1 interferon, activated plasmacytoidinic cells, and we also found exhausted T cells as well. So the next question here is what happens at later time points? And the interpretation of the data was made more confusing because all of our patients were fully vaccinated, so the immune profile then is skewed by vaccination. And then between 18 months and 24 months, some of the patients had breakthrough infections with Omicron. And this is just a schematic to show you what we've done. We did cellular assays, phenotyping. We've done actually now single-cell RNA-seq for 8 months and 24 months. We've done serum antibodies and serum cytokines, and we looked at this longitudinally. So this is using the Euroimmune Total Spike IgG assay kit. We found higher spike IgG at the earlier time points. It wasn't significant, but it was about 2-fold higher in the long COVIDs in the red and the matched controls in blue. That slightly reduced over time, and then you can see once they got vaccinated, the levels were no different between the 2 groups at 24 months. Interestingly, there was significantly higher anti-nuclear capsid IgG at the 3-month time point in the long COVIDs that reduced over time, and then increased again at 24 months. And the black dots are showing you the patients that had reinfection with Omicron. We also have in our CAT3 facility a live neutralization assay. And surprisingly, it showed that the long COVIDs had higher neutralizing antibody titers all the way up until 8 months post-infection. At 12 months and then following vaccination reinfection, the neutralizing titers increased and there was no difference between the two groups. So then we had a look at B cells, and this work was done in collaboration with the Doherty Institute in Melbourne. There was no real difference in the frequencies of total CD19 positive B cells. We looked at plasmablasts, we looked at recently proliferating B cells, and there was no difference there. We also used what we call B cell tetramers for spike and nuclear capsid to find the SARS-CoV-2 specific B cells, and there was no difference in these memory B cells over time, and they did increase in terms of the spike positive B cells at 24 months. So from our previous publication, we had 6 candidate cytokines that were most highly associated with long COVID, and then we had a look at again at these 6 cytokines at the 2-year time point. Interferon beta and interferon gamma was still slightly higher in the long COVIDs, but as you can see, the black dots there are reinfection. So when we do a sensitivity assay and remove the reinfected patients, it's no longer significant. We also showed early on that there was innate cell activation using HLA-DR and CD38 co-expression. It was higher in monocytes at 3 and 8 months, no difference at 24 months. There's reduction in both the the myeloid dendritic cells and the plasmacytoid dendritic cells over time, and there was no difference at 24 months. We also saw the same trend with exhaustion markers, so PD-1 in CD8s that were higher in the long COVIDs at 3 and 8 months were no longer different at 24 months, and a reduction in TIM3 as well in the CD4 compartment. So then we went to do extensive single-cell RNA sequencing. So we had 10 long COVIDs, 10 matched controls, accumulated over 80,000 cells, and did this at 8 and 24-month time point to have a look at the cell proportions or cellular changes over time. And what we saw in the long COVIDs here in the middle panel, an increase in naive B cells over time, an increase in CD4 naive T cells over time, and an increase in B cell memory over time as well, which is quite interesting. And it's also important to note that we didn't see a difference in the in the proportion of innate subsets between long COVIDs and matched controls at any time point. So when you look at this, just focus on the 24 months using the UMAP, and every dot here represents a cell. We saw no difference in the cell proportions. In the table below, there were slightly lower naive CD4s compared to, in the long COVIDs compared to the matched controls, and the same with CD8s, but this is no longer significant. And then we just focus on those naive cells that we saw that were absent in the 8-month time point. At 24 months, it looks like they've reconstituted. So there was no clear or distinguishing difference between the two groups. We also then had a look at using a published interferon response score. So this is looking at over 200 genes that are either interferons themselves or within the ISG pathway to see if we can see a difference in the interferon response score. And interestingly, the CD14 positive monocytes still had a higher interferon response score compared to the matched controls at 24 months, but this was not significant or different in the other innate cell subsets. And then we also used a published T-cell exhaustion score to calculate using the transcriptomic data to see if there was any difference between the adaptive cell subsets, and there was no difference there at the 24-month time point. So we looked at the patient-reported outcomes, and this is a standardized, internationally recognized EQ5D 5L quality of life score, and that's a cumulative graph showing you longitudinal the trends over time. In the matched controls, you can see they had a higher EQ5D score to start off with at 4 months, and then doesn't really change over time. 1 is a perfect health score. In the long COVIDs, they started off much lower, and some of them very low. However, in a majority of these patients, it did improve over time, and this became higher at the 24-month time point. And I just wanted to highlight here, when we asked them at the 24-month questions on full recovery, return to work, return to exercise, most of the long COVID patients were able to go to work, return to exercise. 62% of our patients actually have recovered at the 2-year time point. 38% had not. So just to summarize, the elevated interferon gamma and beta we saw at the 24 months was actually skewed by reinfection. The initial elevated anti-nucleocapsid IgG and neutralization titers were no longer different at 24-month time point, and the innate immune activation and T-cell exhaustion levels reduced over time. And we also saw that reconstitution of naive B and T cells at the 2-year time point. So it's quite optimistic that 62% of our patients have recovered, but there's still 38% that are incapacitated, unable to return to work or return to exercise. So we really want to keep going with our long COVID research. One thing that we want to do now is compare the immune profiles between the ancestral strain and the long COVID that developed through breakthrough infections with Omicron to see if the profiles differ, and then dive deeper into what the drivers of long COVID are. So it's been mentioned before, persisting virus, autoimmunity, inflammatory-induced mitochondrial dysfunction, and activation of other chronic viruses. So I'd like to thank everybody involved in the trial, especially the ADAPT study participants and our funding bodies. Thank you.